Now we will discuss scoliosis, that is adolescent idiopathic scoliosis, specifically that is adolescent idiopathic scoliosis. Adolescent idiopathic scoliosis, a coronal spinal curve more than 10 degrees rotation, affects about 1 to 3% of the children. Despite identification of numerous associated genetic loci and a pattern of autosomal dominant inheritance with a variable penetrance, a clear etiology of this condition is not known clearly. It affects females more than the males. For the curves more than 30 degrees, the ratio is 1:1 for male to female for smaller curves. Right thoracic curves are most common. If it is a left thoracic curve, then you have to do an MRI scan to rule out cyst or a syrinx. Coming to the etiology, pathogenesis and progression. Already we discussed about etiology. It is genetic, autosomal dominant, but in majority of the cases, etiology is not clear. The pathogenesis is because of anterior overgrowth of the vertebral bodies, and the progression is related to curve magnitude and the amount of skeletal growth remaining. Coming to the examination, you have to evaluate the patient properly. You have to undress the patient upon the upper back and lower back. You have to measure limb length. There will be inequality. You have to examine for the midline skin defects like hairy patches, the dimples. These indicates signs of a spinal dysmorphism. Shoulder height difference will be there. Truncal shift will be there. Rib rotational deformity will be there, and waist asymmetry and pelvic tilt have to note in the examination of a scoliosis. X-rays are recommended in all cases of scoliosis. You have to do whole spine X-ray, standing, PA and lateral. Corpse angle you have to measure. If it is more than 10 degrees, then it is defined as a scoliosis. Intra-observer error of 3 to 5 degrees is reported in the literature. You have to measure spinal balance. A coronal balance is determined by alignment of C1 plumb line to central sacral vertical line. Sagittal balance is based on C7 plumb from the center of C7 to the posterior superior corner of S1. In the X-ray, you have to define stable zone, stable vertebra, neutral vertebra, end vertebra, apical vertebra and clavicle angle. Stable zone is between the lines drawn vertically from the lumbosacral facet joints. Stable vertebra is most proximal vertebra, that is most closely bisected by central sacral vertical line. Neutral vertebrae, rotationally neutral, that is spinous process equal distance to pedicles on PA X-ray. End vertebra. End vertebra is defined as the vertebra that is most tilted from the horizontal apical vertebra. Apical vertebra. The apical vertebra is the disc or the vertebra deviated farthest from the center of the vertebral column. Clavicle angle, best predictor of post-operative shoulder balance. In some cases, you have to do an MRI scan. What are the indications for MRI? A typical curve pattern, that is left thoracic, short angular curve, apical, kyphosis or a rapid progression. Excessive kyphosis, structural abnormalities, neurological symptoms are pain, foot deformities, symmetric abdominal reflexes. If these things are there, you have to do an MRI. A syrinx is associated with the abnormal abdominal reflexes and a curve without significant rotation. There are different treatment options are there: observation, bracing and surgery. Observation is indicated if the Cobb angle is less than 25 degrees and serial radiographs are required to monitor for progression. Bracing is indicated if the Cobb angle is 25 to 45 degree and It is effective for flexible deformity in skeletally immature patients, that is risers 0, 1, 2. The goal is to stop progression, not to correct the deformity. There was one study in 2013 on effects of bracing. It was a prospective randomized study. According to this study, bracing lowers the rate of curve progression and need for surgery. Rate of treatment success was almost 72% after bracing. That means it is quite effective. Bracing lowers the rate of curve progression and need for surgery compared to only observation. Success with the bracing is related to number of hours worn, with more than 16 hours per day needed for an optimal outcome. Lumbar curves have a higher chance of success with a brace than thoracic curves. The curve type also matters, as already we discussed. Brace success is related to curve type in patients with adolescent idiopathic scoliosis. Lumbar curves have a higher chance of success with a brace than thoracic curves, and the rate of surgery or progression to more than 50 degrees is related to the location of the curve. It is 34.1% in the combined thoracic group and 15.4% in the combined lumbar group. Thoracic curves are at a greater risk for brace failure than lumbar curves despite similar initial curve magnitude and average amount of daily brace wear. Don't neglect scoliosis. Left untreated, curves greater than 50 degrees will likely to progress over time, and progression increases rate of back pain. 22% of the patients complained of shortness of breath during everyday activities. Untreated lumbar idiopathic scoliosis causes little physical impairment other than back pain and cosmetic concern. Now, you have to correct the deformity if it exceeds the prescribed limit. Nowadays, instrumented deformity correction is advisable with a spinal fusion. Posterior only approaches are most common technique. Lenke system is most widely used system. You have to select reasons for fusion. Major and structural minor curves are included in the instrumentation and fusion, and non-structural minor curves are excluded. You have to count vertebra correctly. Variations in the number of the thoracic or lumbar vertebra were found in 10% of the patients with adolescent idiopathic scoliosis. This variation in the vertebra is identified in 0.5% of the radiology reports. Assessment of possible variation in the number of vertebrae is important to help avoid surgery at the wrong vertebral level. Antifibrinolytics in surgery. Tranexamic acid and epsilon aminocaproic acid reduce the operative blood loss but not transfusion rate. Tranexamic acid is more effective at reducing post-operative drainage and total blood loss compared with the epsilon aminocaproic acid. Increased surgeon experience lowers the operative time and blood loss and improves outcome scores. Safety during surgery. Reversible intraoperative neurophysiological monitoring alerts in patients undergoing arthrodesis for adolescent idiopathic scoliosis. If this facility is there, that is best to avoid complications. Coming to the complications of scoliosis, if left untreated, it will lead to progression and back pain, deformity. In patients undergoing surgery, some patients will have neurological injury, pseudoarthrosis, infection, flat back syndrome, superior mesenteric artery syndrome, and hardware failure. Coming to the conclusion, scoliosis is defined if there is a curve more than 10 degrees with a rotation. The etiology is not clear or not known. You have to investigate the patient properly to rule out any congenital abnormalities in the spinal cord. Bracing is quite effective in indicated cases. Posterior surgery is common and you have to counsel the patient before surgery about the complications.